All right. Good evening, everyone. My name is Dr. Brad Tragord, and tonight at the online office hours, we get to talk a little bit about clinical practice guidelines and that deal with the carpal tunnel syndrome. This is an update from 2019, and we'll talk a lot about how these apply not just to the national board exam, but also to your clinical practice. So hopefully that's helpful. And you may have to apologize. My voice is a little hoarse from a lot of teaching and talking over the last few days. So hopefully we'll get through this okay. But just a little bit about me. I am the program director and chair, as well as associate professor here at UT Health in San Antonio, Texas. Hopefully some of you have been able to visit here in San Antonio. It's a great place to be. I teach orthopedic physical therapy. We have a fall and a spring semester that I facilitate and have a lot of great adjunct faculty. But, the other great thing I get to do is participate in writing chapter 2 of the review and study guide. So my co-author, Mike Crowell, and I, we really enjoy diving into some of the content. And in particular, we find it relevant to share the clinical practice guidelines and how they relate to the national board exam to you all. And so some of my prior experiences were, I served 23 years in the United States Army as a physical therapist, primarily. The latter end of my career, I was the director of clinical education and taught spine as well as some other direct access and primary care physical therapy, musculoskeletal imaging at the Army Baylor program here, also in San Antonio. You can see my educational background there. I have a Doctor of Science in orthopedic physical therapy through Baylor. Also have my manual physical therapy fellowship through Brooke Army Medical Center and program with Army Baylor. So that's a little bit more about me. So hopefully you're familiar with clinical practice guidelines. Really that's a consensus statement from a bunch of experts in our profession. These come from the Journal of Orthopedic and Sports Physical Therapy. And these guidelines are important to help, not dictate our practice, but guide us. It's really a nice high level evidence base that we can rely on. And we're going to see that the practice guidelines talk through exam, evaluation, and interventions, just like the National Board Exam asks us to think about taking a variety of board exam questions. So it's laid out very well. Speaking of the layout, at this point, I usually like to ask everybody to chime in the text box. When do you plan to take the board exam? Maybe this October or in the future at some other date. Okay, yeah, a couple of January, even next summer. But it looks like, yeah, the majority are in October. And it's always nice to kind of get a checkpoint and remind you, if you have not, is to look at that content outline, right? That's an important part of your preparations. And, reminds you that the big three of musculoskeletal, neuromuscular, and cardiopulmonary take up a largest chunk of what you'll see. But there are all the other systems, that include lymphatics, GI, GU, integumentary, endocrine, and the system interactions itself. And really those non-system things like equipment, technology, safety, and research, we'll take a tiny bit of tonight's lecture or presentation to talk about those, but the focus here will be on musculoskeletal, of course. And then looking at the exam from a different view is, what does it look at? The examination, whether that be the subjective or objective content. Is it the evaluation, your ability to differential, diagnose, evaluate prognosis, or interventions? And again, those three together make up the vast majority of test questions that you'll face. And again, the clinical practice guidelines nicely mirror those three. All right, just a total number of questions. You can see, expect to be around 50 in the musculoskeletal content of the NPTE. You can see them broken down. It's pretty much well spread between the PT exam, evaluation, differential prognosis, but then also intervention. Before we go through the practice guidelines, it's kind of nice to review some of your functional anatomy and biomechanics. Maybe a good approach on any body region, whether it be the wrist and hand, or maybe the elbow or the shoulder, is to think about the joint structures that are involved and they're relatively open packed or these resting positions and closed pack positions, and the importance that each joint has in those different positions, whether it be from an examination standpoint and that open pack position, which is a position of comfort. So if there's swelling, it's you'll find a joint in that resting or open pack position. Um, Maybe the closed pack position, a position where you need to challenge or load the joint region to make sure that it has an end feel and understand how that closed pack position is fully approximated to handle loads. So there's lots of reasons why you want to consider those open and closed pack positions. Also, from an intervention standpoint, knowing the open pack positions might be a place where you would start some manual therapy techniques. Things to modulate symptoms or pain would often be done in that open pack position, where you might progress your interventions to a closed pack position or positions of more congruency as you're looking to progress function. Okay, and here let's continue our assessment, not just from a mechanical standpoint, but more anatomical standpoint of the hand and the carpal tunnel itself, and remind ourselves that the wrist contains 8 different bones: the scaphoid, lunate, triquetrum, pisiform, trapezium, trapezoid, capitate, and hamate. And the carpal tunnel is formed by those bones and the transverse carpal ligament. So the contents in the carpal tunnel include 4 tendons of the flexor digitorum superficialis and 4 tendons of the flexor digitorum profundus. And you can see that outlined in the image in the lower right. It also has the flexor pollicis longus. And then in yellow, superficially, we've got the median nerve. And that's what a lot of the focus on along that median nerve will be at tonight, and the compression or potential aggravation of that structure. The flexor retinaculum, also known as the transverse carpal ligament, spans from the pisiform bone and hook of hamate to the ulnar side, or correction, on the ulnar side of that hand, all the way to the scaphoid and trapezium on the radial side of the hand. It's considered to be this tie beam apparatus that maintains the arch of the carpal tunnel. Now, that median nerve is vulnerable to compression from a variety of sources, external or internal forces, because it's the most superficial structure within the carpal tunnel itself. Now, the carpal tunnel syndrome has been considered the most common compression neuropathy of the upper extremity. Now, it's important for you to notice that, because in terms of what you're going to likely see on the board exam, this is the most common compression neuropathy of the upper extremity. So a variety of pathoanatomical factors have been implicated in the development of carpal tunnel syndrome. These would include elevated pressures within the carpal tunnel, ischemic or blood changes within the nerve, and compression from adjacent structures. The classic sensory or motor innervation of the is from the median nerve of the hand, which is affected in patients with carpal tunnel, which includes the sensory branches of the thumb, index, and middle, and radial half of that ring finger, while the motor branches innervate the first and second lumbrical muscles, the opponents, and the abductor pollicis brevis. It also includes the superficial portion of the flexor pollicis brevis muscle. The sensation to the skin directly over the carpal tunnel and the thenar eminence is typically not affected in carpal tunnel syndrome, because these areas are supplied by the palmar cutaneous branch, which branches from the median nerve 5 centimeters proximal to your wrist crease. So again, that area of the wrist may be preserved in carpal tunnel syndrome. So the Academy of Hand and Upper Extremity Physical Therapy and the Academy of Orthopedic Physical Therapy of the APTA have an ongoing effort to create these evidence-based clinical practice guidelines for management of patients with musculoskeletal impairments. Reviewing CPGs are a great way for us to review and prepare for the national board exam and our entry-level practice. The hand pain and sensory deficit CPG that we're going to go through tonight include the diagnosis, prognosis, intervention, and assessments for outcomes for carpal tunnel syndrome. The authors outline interventions supported by the current best evidence to address impairments, activity limitations, and participation restrictions associated with carpal tunnel. The guideline was issued in 2019, and so we would expect that an update should be coming in the next year or so, where these practice guidelines are typically updated every 5 years. So there's a lack of consensus on the clinical classification of carpal tunnel, especially in the absence of electrodiagnostic studies. Classifications based on clinical signs and symptoms alone, or in combination with electric diagnostic studies, are largely based on anecdotal evidence, expert consensus, or pathophysiology of nerve compression. According to evidence presented, the frequency of symptoms, which would be mild, demonstrating more intermittent symptoms, and moderate, which would demonstrate more consistent or constant symptoms, seems to be a factor in distinguishing mild from moderate carpal tunnel. Thenar muscle atrophy is a clinical sign that distinguishes patients with severe carpal tunnel syndrome. An individual with severe carpal tunnel, as evidenced by that atrophy or electrodiagnostic findings, they really should be considered appropriate for referral for surgical consultation. The intrinsic factors with the strongest link for carpal tunnel syndrome are obesity, age, and the female sex. The risk increases linearly with body mass index and age. The risk doubles in individuals with body mass index greater of 30 kilograms per meter squared and in those over the age of 50. Female sex increases the risk by 1.5 to upwards of 4 times. So these factors are important in your understanding of cases on the national board exam or in clinical practice. Intrinsic risk factors linked to carpal tunnel to a lesser degree would include diabetes, osteoarthritis, previous musculoskeletal disorders, cardiovascular disease, hypothyroidism, and a family history of carpal tunnel syndrome. We'll talk more about things like a risk ratio index or having a short stature as well later on in the presentation, and how those are coupled with an increased risk for developing carpal tunnel syndrome. There are also occupational risks. Things that have the strongest association with carpal tunnel is forceful hand exertion. There are some associations with the presence of carpal tunnel and high psychological work demands. And computer users reportedly do not have an increased risk of carpal tunnel syndrome when compared to the general population. Now, common differentials. So again, talk about evaluation and differential diagnosis. Common differentials would include cervical radiculopathy, thoracic outlet syndrome, diabetic or polyneuropathy, and other median neuropathies such as pronator Terry syndrome. An upper quarter screen in your exam and your studies is warranted to rule out anything like a proximal nerve lesion or other serious medical condition. So we're going to talk a little bit about this, but the point here would be is as you prepare for the board exam and you look at the wrist and hand and carpal tunnel syndrome, these would be important differentials to learn about or deepen your understanding. So you're going to notice that all the differentials lead us as clinicians to consider the importance of a complete upper quarter neuromuscular screen. Listed on this slide are some common components of your upper quarter screen, which would include observation, clinical or cervical range of motion, palpation, but then sensory, motor, and reflex testing. The purpose of the upper motor screen is for you to determine what anatomical region of the upper body is contributing to your patient's symptoms and to rule down or rule out gross sensory or motor neurologic deficits. The cervical spine is probably the most common source of referred or radiating pain into your upper extremity and hand. If the problem is from a direct compression of the nerve root or spinal nerve, like a cervical radiculopathy, the symptoms would either sensory disturbance or motor weakness. You would see sensory disturbance or motor weakness. More commonly, the cervical somatic tissues like ligaments, facet joints, discs, or muscle can refer to the upper extremity without direct neural compression. And in either case, the goal of your exam is to reproduce the chief complaint and the chief symptoms with range of motion tests or special tests. This might scare a few of us, right? The old brachial plexus. The neurological exam consists of a series of tests to determine the patient's problem if it's related to the spinal nerve root or a peripheral nerve or potentially the central nervous system. And you're likely familiar with the brachial plexus at this point in your studies. But I want to encourage everybody here to create several cases on their own and think versus memorize something like the brachial plexus, right? It's, look at all the different potential pathways that could lead to dysfunction, where you start and where do you finish. In the absence of any trauma, think about one spot and create a case on what could be going on. I was sharing in a class scenario today about an injury to a young man that fell off a bicycle and hit his shoulder on the ground and splayed his neck, in the opposite direction, creating a tension type injury that resulted in numbness and weakness of the upper extremity. And this was a classic stinger kind of mechanism where C5 and C6 nerve roots and or the axillary nerve were implicated. And this would be an example where we would do the the upper quarter screen. So anyway, you can create different scenarios like that on your own, but getting back to the clinical practice guideline now and carpal tunnel syndrome, it is a common musculoskeletal condition. And for women, the prevalence, like we mentioned, is twice that of men, basically 10% compared to 5.8%. There is a marked increase in the prevalence with increasing age, where 3.7% occurs in younger individuals than 30, and upwards of 12% in those over the age of 50, according to the clinical practice guideline. Tests and measures used to assess individuals with complaints consistent with carpal tunnel syndrome would include symptom assessment, your provocation test, and different sensory measurements. And we're going to go through all of those here tonight. It is not uncommon for patients to present with bilateral symptoms of hand numbness or tingling or pain. And so it's important to remember that carpal tunnel syndrome is not unheard of to be bilaterally presenting. Night pain or hand weakness, especially in the thenar region, are also common complaints. If you're not familiar, this is the cat's hand diagram. The cat's hand diagram is used to assess the presence and characteristics of different symptoms. Patients are asked to indicate the location of their symptoms of either pain, numbness, or tingling, and or decreased sensation, and draw it out or indicate that on a picture of the hands. And you can see in the table in the description below the likelihood of carpal tunnel syndrome based on the diagram is rated as follows, either as classic carpal tunnel syndrome, where symptoms would be in at least 2 of 3 fingers completely innervated by the median nerve, which would be the thumb, index, and middle finger. This category is excluded if symptoms are outlined in the palm and dorsal or dorsum of the hand or proximal to the wrist. Another category would be probable carpal tunnel syndrome. This is the same as classic, except palmar symptoms are allowed as long as they are not along the ulnar side of the hand. Then you have possible carpal tunnel syndrome. This is where symptoms are in at least one of either the thumb, index, or middle fingers. Symptoms on the dorsum of the hand can be included. And finally, unlikely carpal tunnel syndrome. This is where no symptoms in any of the fingers would be allowed or outlined. All right, I'm going to break it up tonight. So instead of asking questions all at the end, I need to test your kind of your knowledge throughout, even before we go through the content. So what I'm going to do here is I'm going to populate a poll. And as you read this test question, I'm going to give you about a minute to answer the question on your own. And then we'll go through kind of some key components of the question and the answers themselves. We'll go through the content and do that moving forward in this lecture. So let me populate a poll for you. Hopefully you can see that. And I'm going to give you about a minute to populate your answer here. Okay, just a few more seconds on this one. All right, I'm gonna go ahead and end this poll, and you'll see what are we looking for here? Well, we're looking for a special test and something that helps confirm the diagnosis of carpal tunnel syndrome. And you all are aware of the Phalen's test. Excellent. So great job. Now, that's the correct answer. And what we're going to do here is go through some of the reasons why these other potential special tests or assessments were not correct. But again, you all are familiar with the Phalen's test, so we're not going to spend all that much time on this particular question, except what I do want to say is in the picture here on the upper left is an example of the Phalen's test, right? So the dorsums of the hand placed together, held for approximately 30 seconds, upwards to 45 seconds. And what are you trying to do? You're trying to reproduce numbness or tingling throughout that median nerve distribution here. In the lower left, you might see something like the compression test. This is where the clinician applies direct pressure over the carpal tunnel at the median nerve between the thenar and hypothenar eminence for 30 seconds, assessing for any numbness, pain, or paresthesia. You also have listed here is the Tinel's test. So this is a test over the area of the median nerve where you're tapping it gently and looking for that reproduction of symptoms. Carpal tunnel syndrome can be ruled out with a negative Phalen's, a negative Tinel, and an absence of nighttime symptoms or muscle weakness. If you cluster those findings, you can really rule down or rule out Phalen's test. All right. Let's go ahead and move on to another question since you all got that one so well. So I'll relaunch the poll and give you about a minute for this one. All right, there's a minute, so I'll give you just 5 more seconds to put an answer in. All right, going to go ahead and end that poll. And what I'd like to think about here is, what is this test question asking about, right? So carpal tunnel is suspected, and the question is asking us, what physical examination item is best used to corroborate or to help prove or rule in this disorder or diagnosis? And the answer here is this Semmes-Weinstein test, right? So we had a little bit more variability on this one. So the Semmes-Weinstein test, if you're not familiar, is the use of a monofilament test that carries both sensitivity and specificity, and we'll talk about those in a second here, to help you rule in the condition. Now, the other tests and measures are helpful, and so we're going to talk a little bit more about those as well. But when examining a patient with suspected carpal tunnel, the practice guidelines suggest that we use the Semmes-Weinstein monofilament test using 2.83 or 3.22 monofilaments as the threshold for normal light touch sensation and static 2-point discrimination of the middle finger. Clinicians provide light pressure to that monofilament until it bends slightly, making a C shape. This is repeated 3 times. A positive test for carpal tunnel is when that patient, with their eyes closed, cannot report what digit is being, receiving this various pressure. Okay, so that's important to note there. So we'll talk about some questions towards the end as well. So I know if you want to question any of these, we'll come back at the end and hit them again. So you can see, though, is that with that 3.22 specificity, if the patient cannot discriminate that, you have a very specific way to help rule in or rule out carpal tunnel syndrome. Now, stop sharing that. Okay. Now, the upper limb tension test, there's some conflicting evidence on the diagnostic accuracy and clinical utility of the upper limb tension tests and these dynamic tests. For those not familiar with the upper limb tension test, you place tension on a nerve in incremental steps to help evaluate a patient and determine if their symptoms may be caused in part by irritation of a peripheral nerve. In order to call an upper limb tension test positive, 3 things really have to occur. The symptoms reproduced must be the same for which the patient is seeking treatment. You really must be able to change the symptoms by modifying the tension placed on the nerve in a joint distant to the site, and there must be a difference from side to side. Before you start the test, it's really important to start asking the patient about their current state of symptoms. Get the patient supine, in this case, asking them, do they have symptoms? And for the median nerve, work through a process such as depressing the shoulder, abducting the shoulder, supinating the forearm, extending the elbow, wrist, and fingers. And I encourage you all to go to the different tables outlined in this review and study guide to think about the upper limb tension test. Generally, these carry sensitivity and help you rule down or rule out a condition. In some upper extremity conditions clustered with other signs or symptoms, they may be useful for us to help rule in, but not yet for carpal tunnel syndrome. I will go back to the the Finkelstein's test, which is a test for compartment first injury to the flexor pollicis, extensor pollicis longus, like nursemaids, or I'm sorry, not nursemaids, but irritation of that first compartment. Watson's or scaphoid shift test is instability of the scaphoid itself. And we'll go through those a little bit more later. All right, another thing in terms of the special tests and measurements that you need to be familiar with for carpal tunnel syndrome outlined by the practice guidelines is the risk ratio index. Clinicians can measure the risk ratio index by using a pair of calipers or a tape measure where the A to P measurements and the medial to lateral wrist width at the distal wrist crease is then compared and calculated by dividing that AP wrist width by the medial lateral width in centimeters. A positive test for carpal tunnel syndrome is a risk ratio index greater than 0.67. And so that's a special test that you can use. Now, used in isolation, the risk does not appear to have strong accuracy, but when coupled with some of these other tests, it is of help. Clinicians should use or assess and document the patient's age, whether shaking their hands relieves their symptoms, sensory loss in the thumb, and the risk ratio index, again, that we just mentioned, greater than 0.67, and scores from the Boston Carpal Tunnel Questionnaire, this severity scale, they should be documented. The presence of 3 or more of these clinical findings has been shown to be acceptable to help diagnose carpal tunnel syndrome. The Boston Carpal Tunnel Questionnaire, listed on the right, is a questionnaire that examines symptom severity, overall functional status of patients with carpal tunnel syndrome. The symptom severity scale with 11 questions is scored on a Likert scale of 1 to 5, and the functional status scale with 8 questions is scored from 1 to 5. 1, no difficulty, 5 is difficult. All right, so that's more examination, tests, and measures. But let's keep going on to the next section, which would be some interventions, and relaunch the poll and see how you're doing with your intervention knowledge. Again, I'll give you about a minute to read through this case, question, and answer. All right, so maybe 5 more seconds and get your answers in. All right, I'll go ahead and stop this poll for you. And we'll share the results here. So a little bit more of a distribution. And very good. So carpal tunnel syndrome is suspected, but what we have is a mild carpal tunnel syndrome, not moderate or severe, but mild. And so in this case, the best intervention and the best indication here is neutral wrist orthosis at night. Now, could you use the wrist orthosis during work hours? Absolutely reasonable. But what we're going to focus in on is using these recommendations based on the evidence, which is using the neutral wrist orthoses at nighttime. So in the upper left, that's what it looks like. Could you then expand that clinically to put it during the day? Certainly you could. So I agree, both B and C would be appropriate, but if you're to solely look at what the recommendation is, so moving forward and recommending it to your patients, you would start off at nighttime. Maybe clinically you would expand that to the daytime, understand. So there are many interventions available to us as PTs for the rehab of patients with carpal tunnel. There's really just the one intervention that was rated with B-level evidence per the practice guideline. The rationale for using static wrist orthoses at night while sleeping is based on theory, reducing your tendon and nerve movement through the carpal tunnel, thereby reducing inflammation, immobilizing the wrist, and um, immobilizing the wrist in the position of least internal pressure in the carpal tunnel, so that neutral position, altering the shape or the dimension of the tunnel to increase its space, and reducing contents by positioning the wrist and fingers to prevent lumbrical muscle from being aggravated. These are all potential theories that have been given. One note is, according to the guideline, clinicians actually should not use low-level laser therapy or other types of laser or light therapy with carpal tunnel syndrome. I think really that's evolving now as more research comes in, and we'll see what the next clinical practice guideline suggests. Clinicians should not use iontophoresis in the management of mild to moderate carpal tunnel syndrome as well. That's recommended in the clinical practice guidelines. Now here, the next slide, clinicians may suggest wearing, adjusting that wear time of orthoses to include daytime, symptomatic time, or full time when night only use is not effective in controlling symptoms. So if you selected B in that answer previously, you're correct, and it's unlikely the national board exam is going to tease out such a fine distinguisher there. But I want to challenge a few of you all and think about the priority of what the clinical practice guideline suggests, where you could start with nighttime splinting and then progress, adjusting that wear of the orthotic device. Clinicians can perform manual therapy directed at the cervical spine and the upper extremity for people with mild to moderate carpal tunnel with short-term benefit. We can use a combination of orthotics like a wrist splint and a stretching program for mild to moderate. And we can perform even phonophoresis with non-surgical management of patients with carpal tunnel syndrome. Using things like IFC for short-term pain relief is a recommendation. It just has lower level evidence. This is a nice process model that we've walked through tonight. It's straight out of the practice guidelines. If you're not looking at this or familiar with this, clinicians' perspectives or the table summaries in the clinical practice guidelines is a really good Cliff Notes versions for you to study and to consider, with the level of evidence outlined for diagnosis or evaluations, outcomes, and intervention strategies. Probably need to focus in on your A and B level evidence as a priority. So I do have a few more questions for you all to go through. So maybe a little bit of a summary of what we did tonight. So let's read through this next test question and see what you put. Give you about a minute for this one. So you can see in that diagram where a patient has written out or drawn out what their symptom map is. And this is asking you to diagnose based on that diagram alone. Maybe just 5 more seconds for folks to put in an answer, 5 or 10 more seconds. All right. I'll stop that poll. Looks like a lot of folks were kind of torn between classic and probable. And that cat's hand diagram is really used to assess the presence and characteristics of different symptoms. Patients are asked to indicate the location of their symptoms, pain, tingling, numbness, maybe decreased sensation, and they outline those things. The likelihood of carpal tunnel syndrome is based on two factors of symptoms in two of the three fingers, completely innervated by the median nerve, thumb, index, and middle finger. As classic, the category is excluded if symptoms are outlined in the palm. And probable is the same as classic, except for the palm are allowed. And so this is probably considered the more probable pattern. But I think if you listed classic, it's reasonable to put that as well too. Really close. So the others clearly not, and really only one or two folks put those there. They'd really have much less issues there. Okay, let's move on to one more question here. Give you another minute to look at this one. Give you about 5 or 10 more seconds if you can. Get your answers put in. All right, I'm going to end that poll. Big question here is severe carpal tunnel syndrome. So remember, we have mild, moderate, and severe. We do see atrophy. And now we have a dilemma. What do we do? Do we treat them with general stretching, phonophoresis? Well, that's probably more for the mild. Prescribe neutral wrist orthoses. Again, that's a mild condition. Now refer to surgical consultation or refer to primary care for a full neurological workup. Both would be considered appropriate answers. I agree. So I don't think you're wrong in either case here. But if you had to choose one, the guidelines kind of suggest that a surgical consultation is appropriate. So if you were to refer to primary care, it would be to primary care for a surgical consultation follow-up. And neurological follow-up or workup at the primary care level would be helpful, but you would want to make sure you recommended that this patient also be considered for referral to an orthopedic surgeon or a surgeon that handles wrist and hand specifically. So it can be difficult. We got to make them tricky for you all, but overall, it's you can tell you're on the right track with these things. All right. So great job tonight with these. What I'm going to do right now is we had a question earlier about some different factors, and I wanted to go back and kind of cover that again with y'all. I think it was, I think we're talking about carpal tunnel syndrome is suggested that it can be ruled down if you have a negative Phaleins test, a negative 10L at the carpal tunnel, and the report of absence of nighttime symptoms or muscle weakness. So the practice guideline, if you want to cluster those findings, that should help you do that. So the other thing we mentioned later on in the presentation, and I think that was for Kelsey, yes, a negative Phaleins, negative 10Ls at the wrist, but also they would need to have a subjective response or comment that there's no nighttime symptoms or no muscle weakness to help rule down carpal tunnel syndrome with that. But then if you go down later, there's strong evidence with this diagnostic cluster here to rule in, right? Those criteria would help you rule out or rule down. So those were more sensitive criteria. Here you have more specific criteria on the order of 0.99. So when you have a 3 or more of the following, this is called the flick sign where you shake their hands. That wrist ratio index where you compare the AP to the medial lateral width in centimeters. When you conduct the symptom severity scale and they report more than 1.9, if they have diminished sensation in the median nerve field, and or if they have an age of greater than 45, if you have more than 3 of these, then you have a heightened concern of ruling in carpal tunnel syndrome. Does this help? And at this point, I think we're nearing the end. So if you have other questions, feel free to share those as well. All right. Yi King, I think we addressed rule in and rule out, I think, there just now. And is it Belinda? Remind me what number 4 rationale, what question? This one here or a prior question? Is it 4 or number 4? I think maybe is what you're sharing. Yeah. So yeah, this drawing is a little confusing. I think what you see here, if I'm not mistaken, right? So I think when we have carpal tunnel syndrome diagram, the symptoms are in at least 2 of the 3 fingers, which we do have here. Excluded if symptoms are outlined in the palm and the dorsum of the hand. And so that's what I'm trying to point out here is if there's more palm type symptoms, it could rule this down. Or if it's more just the thumb, it would be considered probable. So this is, I'm sorry, classic. So this is more probable only because you have a little bit more of the palm aspect reported. Again, we're kind of splitting hairs with this one, so if you chose classic or probable, I think it's fine. But this, because it spills over to the palm of the hand with that thenar eminence, it would probably fall more into the probable category for this one. If it was only like a numb thumb, and then the index finger, that's more classic pattern. Okay.
Could you explain what the possible and unlikely pattern is? I'm not well acquainted with its cat's hand diagram.
Yeah, I'll just read it one more time for us all. And it is new, and I would go back to the practice guidelines yourselves, and if you use this, but the classic carpal tunnel syndrome for the CATS diagram is that the patient has symptoms in at least 2 of 3 fingers that are innervated by the median nerve, and that's your thumb, index, and middle finger. Remember, your ring finger is partially innervated by the median, but also has your ulnar nerve, so that's out. This category, this classic, is excluded if there's symptoms in the palm or the dorsal aspect of the hand, or if there's symptoms proximal to the wrist. So for whatever reasons that we explained, that there's branches of the median nerve that innervate those areas, because they branch off proximal to the carpal tunnel, if you have palmar numbness, it it puts those into a more probable pattern, which is the next pattern, which is the same as the classic, except they're allowed to have palmar numbness or dorsal sided numbness. Okay. And then the third category is the possible carpal tunnel, which is symptoms in just one of those digits, like just the thumb, or just the index finger, or just the middle finger. And then unlikely, which is really no symptoms in any of the fingers, but instead maybe other complaints or concerns. Okay, that's probably enough for tonight in terms of the CATS diagram. It's probably the limit of my knowledge and use of it as well. Hopefully that's helpful to clarify. Okay, let's go to another question about upper limb tension test from Ryan. It's potentially poor in diagnosing carpal tunnel, but would you give the upper limb tension test as a treatment for flossing? All right, this is good. All right, I'm talking a little bit outside of the scope of the clinical practice guideline. I will clarify this. The upper limb tension test is generally a sensitive test. When it is negative, right, when it's not reproducing the symptoms that the patient came in for, it can maybe help us rule down. Now, those same sequences of movements that we do for the upper limb tension test, absolutely, Ryan, can become a way that we can treat, whether that be flossing or tensioning techniques for things like carpal tunnel syndrome or other upper extremity peripheral nerve injuries or problems. It's not currently recommended as a intervention, but we are seeing evidence build over the last couple of years of using these tensioning techniques or flossing or gliding techniques of the nerves as treatments for things like carpal tunnel syndrome. And I won't be shocked if we see them mentioned more or prioritized more going forward. Anecdotally, I would say if patients are not responding to things like an orthotic, or if they're looking to do augmented therapies like manual therapy or stretching, I would personally recommend a trial of these. One thing I would mention is making sure that you look at how nerves behave in patients. Nerves do have a tendency to have lingering symptoms or what we call latent pain, where the patient may tolerate movements for a period of time, but then they will pay the price, or they'll find that after stressing or stretching a nerve, they get really aggravated. So your ability to follow up with your patient and ask them how they are doing in the clinic and the following day is pretty important. I hope that helps you, Ryan. Okay. And then the last question I see here listed is discussing the final question between referring for surgical workup compared to primary care physician. I didn't know if PTs have the power to refer for surgical consultation. And this is a good point. If you refer to a primary care provider, it may not, the better answer be refer to a primary care provider to consider workup for a surgical recommendation. So they would be the one to recommend surgery, but you may need to communicate your concern for that. So it's a little bit misleading. I would agree that answer. But no doubt, however you do it, you do want to recommend getting a surgical consultation, whether that if you have direct access abilities to reach out, or if you work in a health system, maybe the military, the VA, or civilian systems that you work hand in hand with orthopedic surgeons and you can communicate directly with them, absolutely would be appropriate and recommended to get them a surgical consultation as soon as possible. That said, if you're in an environment where you can't do that, recommending to the primary care provider is the best response. But again, not just limited to a neurological exam, but to consider carpal tunnel in the severe form and to look at surgical intervention referrals. Okay. That's probably enough questions for tonight. We're getting close to 7 o'clock. Okay, I will mention this. Primary care provider interaction and communication is recommended first in most cases, but with a comment or in your note that practice guidelines suggest surgical evaluation or examination is indicated for severe carpal tunnel. So as a physical therapist, you've got to be able to be aware if you have a carpal tunnel patient that is in that severe category, if you do not have the ability to refer directly to a surgeon, you would need to get him to a primary care provider, correct? And a neurological workup would be indicated, but you would also make sure that that primary care provider knows that this is a carpal tunnel case that's severe and that you would ask them to help you and help the patient find a surgical, a surgeon for evaluation. Please, if you want to reach out to me on email, or for those that want to stick around, I'm going to stop the recording. I can chat with you offline. I'll be here for the next 15 minutes or so. Okay? Have a good night, everyone.